And now let's delve into the actual visit. So we're always, regardless of the type of visit we're doing or the discipline, we're always going to have the same screen when we start the visit, asking us what the purpose is. Let's start with, let's say we're performing a visit, start of care visit for a Medicare patient. If this would have been a Medicare patient, the system automatically would have selected homebound status and that we needed to perform an OASIS document. If we were completing this for a hospice patient, the system would have automatically selected our hospice questionnaire information. But you do have the capability of overriding these. So if you have some special use situation where you actually wanted to complete a patient supervision, you can actually just click the button to include that as part of your normal assessment. Once you have your time in, we make a lot of use of these sliders, which makes a lot more sense when you're looking at this from a tablet perspective where you're using your finger to document most of your visit. Instead of being distracted away from your patient, having to look at check boxes or have to type a lot of information into the system, these slider bars make it very intuitive to be able to communicate with your patient while just using your thumb or your finger to answer the questions. You'll also see that the OASIS questions are automatically compiled in the background for us. So they are, from a regulatory perspective, they're automatically integrated into your software. So you meet all of those requirements, but we've made it a lot simpler to document those. Your patient information screen is just a summary of what's going on with that patient. So if the patient has any new updates to their plan of care, if they have a new physician's order, that information is going to show up right here whenever we get started working with this patient, their DNR status, their triage status, all that's right here at our fingertips. And then we would get started with our assessment. One of the nice things about the new system is that you can effectively go completely electronic. Most of you are using paper-based admission documents, which means you have to get the patient to sign those and then scan them back into the software system. Well, not anymore. Now you actually have all of your admission documents built directly into the software. It comes with some standard templates, but you are able to modify each of those admission documents through the online system, and then you would just say that the patient you've reviewed those with your patient. You have the capability of keying in all of your service information, backup services, communication protocols, consents for photography or videography, DNR status, all of that kind of stuff, and then have your patient actually sign off on the document right there on your tablet. The nice thing about this, again, is, in addition to that being completely electronic, this document immediately goes to your patient portal, so your patient and their caregiver has access to your admission documents in an electronic version, as well as whatever you decide to hand them on paper. But you now have all of your admission documents right there electronic. I should point out that these admission documents are available for all discipline types. And so the other thing we've done is really made it simple to kind of move between the different segments of your visit. We spent a lot of time analyzing nurse and therapy encounters, monitoring kind of the flow from multiple nurses to see how they interact with their patients. And then we took about 2 years evaluating each component of the OASIS of an adult and a pediatric nursing visit, adult and pediatric therapy visits, and we took a lot of time kind of placing those in like little puzzle pieces in the way that we think is most efficient for the patient interaction. One of the big problems with most point of care systems is how much it distracts you from actually rendering patient care. And we did a lot of work to make this system very intuitive so that you're not distracted from actually serving the patient. So what would generally happen is you'd start your initial visit by going over your intake documentation. Then you're going to talk to the patient. You obviously would know what type of house they live in, Usually there are a few people sitting around the nurse. You would introduce them, or they would introduce themselves at that time. You'd be able to take down their information. At that point, you know whether the patient is alone or lives with other people. You'll notice that these mimic the OASIS questions. So if you're doing it, they're available for adult and pediatric, OASIS or non-OASIS. But for those of you who are completing OASIS, these are actually stored in a manner that complements your OASIS documentation. So you immediately can answer whether the patient has any assistance available. And I'll stop here for just a second because I want to explain one of the key benefits of this new system. Whenever we create your plan of care, one of the problems is that when you pull up a current plan of care for a patient, it almost always says what the agency is going to be doing for that patient, but it almost never explains why. So it will say skilled nurse to instruct on diabetes management or CHF, signs and symptoms of CHF. But other than showing that the patient has a diagnosis of CHF, there's really no medical substantiation for why a nursing agency or a therapy company has medical necessity for actually implementing those protocols. And that's the big connection that's missing with most people's documentation. And it's very hard to make those connections. So we end up, as attorneys, having to go back through all the medical record and try to pull out these little tidbits of information to justify the agency rendering that particular plan of care. Well, what we did with this software system is every single one of these elements is now analyzed, and it tracks back to individual patient problems. And also we have a medical necessity section added to the plan of care that utilizes this information. So for instance, if your patient had mobility problems, we would not only on the plan of care list out that the patient had a timed up and go assessment was performed showing the patient was a high fall risk, we would also show that in addition, the patient only has ADL assistance available in the home less often than weekly, meaning that if that patient falls, it's going to cost the payer not only the cost of the home care agency, but now it's going to cost them an ambulance transfer because the patient has no one else available. Since no one else is available, the patient is at high risk for hospitalization or severe injury or even death because no one is available to help them with their mobility. So the system takes all of those little components and builds it into a story automatically for you on your plan of care. So by looking at your plan of care, if you send that off for an authorization or it goes into an audit review, you have some beautiful documentation that tells the story of why you're doing the interventions that you're doing, why that's justified, and what would happen if home care wasn't involved. So each of these little sliders, in addition to answering your OASIS questions and your clinical questions, it's automatically building that medical necessity story for you. And like I said, for you, Medicare agencies, you can see how your OASIS documentation is integrated directly into the software based upon those slider options. So instead of having to read through all of this text, which you clearly have the capability of doing, we immediately make sure that it's coordinated back with your the simple options. So we'll go through reviewing all your patient information that came over from your intake coordinator, so you can verify that information. And then, usually what happens on an admission visit is we're going to be asking the patient about their health history. So what brings you to home health? So you're very quickly able to link in the main diagnosis codes that affect adults or pediatric nursing patients. So if they had cardio issues in the past, you would be able to say that they had a heart attack, and you'll notice how the system is intuitive enough to immediately ask you those follow-up questions. How many heart attacks have you had? When was your most recent heart attack? And, of course, all of that is building a story for your medical necessity summary on your plan of care. In the background, while also capturing a ton of really relevant data, instead of just having a bunch of text boxes that may or may not apply to the patient. Then we just walk through your 10 diagnosis codes for that patient. So you have the spotlight for that, your severity. We made a simple change, I think is pretty profound. On the current plan of care, on the current 485, most people answer the question of when the patient was diagnosed as an actual date. And then they have to put whether that date is for onset or exacerbation. And universally, that information is incorrect as it's given by the nurse. On almost every chart we've audited, and we've audited a lot, that date is almost always the same for all diagnoses. It's almost always shown as an onset when it really was an exacerbation, which ends up actually undermining the credibility of your documentation. And what happens a lot of times with both adults and children is that a patient may have been diagnosed 5 years ago. We don't know the exact date without digging through all of their medical documentation, which usually isn't available to us. So people will end up making up a date, again, making up or just ignoring whether it was an exacerbation or a new condition. So what we've done is instead of giving you those dates, we've now limited that to these drop downs. So you can basically tell us when the patient was diagnosed, whether that's in the past week, the past month, the past 3 months. Based on that, we're automatically able to justify a lot of your medical necessity. Right? If a patient was diagnosed in the past week, we know that the patient may have or is going to have instability. They're going to need education because they've never had this condition before. If they've been diagnosed in the past month, we can assume that they have some stability, but they're still dealing and transitioning with that condition, to living with that condition. Right? If they've had that condition for the past 5 years, then we know that we have to show some instability somewhere else within our documentation, that the diagnosis code alone isn't going to justify medical necessity for any type of home care services because the patient should be stable. So we'll be looking for things like vital signs that are out of parameter, edema, timed up and go scores that are, show fall risk or even falls within the past few months. The second component of this that I think a lot of our current agencies will like, especially our pediatric agencies that have multiple disciplines, currently when you put in your 10 diagnosis codes or up to 10 diagnosis codes and you're doing a physical therapy assessment, when the occupational therapist goes to do her evaluation, they would see all 10 of those diagnosis codes, and they usually rearrange them, and then that overrides the 10 diagnosis code that the physical therapist put in. So what we've done now is makes it really simple. The first person out to do the assessment would put in all of the diagnosis codes that they know of. When the OT goes out, rather than having to rearrange or change any of the PT's codes, they would just add in their occupational specific diagnosis codes. And all they have to do now is click the little radio button here to say that this is the primary diagnosis code for this service. So rather than having to rearrange or worry about keeping diagnosis codes consistent between all of your different disciplines, you can simply just say that this is now the primary diagnosis code for occupational therapy versus physical therapy. When that happens, that is the diagnosis code that we will use when we bill all of your OT claims. But we'll continue to use the primary diagnosis for PT or for your nursing claims. So again, this makes it really simple to keep everything consistent and your medical necessity in place. We'll walk you through some of your inpatient history for your OASIS information, prior conditions that the patient had. Again, some of the OASIS questions that we just went through, communication section. And then on all of our visits, if we were doing a routine visit, those previous sections wouldn't be there. you would skip immediately to your health status question, and this has been designed in a way to kind of flow with all of your routine visits. So we're going to ask you for your vital sign information, and we'll trend and track that and let you know if there are any type of trends that you should be aware of. Bowel sound issues, again, you're automatically prompted. So in the current system, we have heart sounds has maybe 10 or 15 different check boxes that you always have to look through. Well, now we only prompt you if you say that the heart sounds are irregular. Then we're going to ask you for additional information, or if the patient is short of breath, or if you're doing a pain assessment that shows that the patient has pain, then we start asking you for those additional items. All of your different allergies. Of course, your medication profile is available directly within the software. A neurological assessment with all of your depression screenings built in. Mental status for your plan of care automatically built in. If they have seizures, that type of information is going to show up automatically. You'll have your integumentary assessment, where you can now track your wounds. Very similar to the current version of the software, but a little bit smarter as far as your graphing and trending. You now also have your adult and PD and Norton pressure ulcer assessments built into the system, with automatic scoring built in as well to let you know what your risk factors are for that particular patient. A full mobility assessment, along with a strength assessment. You have 3 different fall risk assessments: the pediatric fall risk, the Missouri scale, or the timed up and go. All your nutritional assessment, which of course immediately goes to your plan of care with nutritional calculations. If the patient has an impaired diet, again, the system wizards you through your different questions. So if they're getting fed by IV, or if if this is a kid on enteral feeding, we automatically ask you to tell us kind of more about that particular equipment, those instructions that will go to your plan of care, whether the patient is compliant or not, urinary status. So you can kind of see, again, just makes it very simple. So if they're not having any problem with urine, it's one click a button with no distractions. If they do have impaired urinary status, then we get into all of the additional questions that may be applicable for that particular patient. If they're incontinent, how often are they incontinent? So the system automatically walks you through those things. Catheter utilization, we would immediately walk you through your catheter assessment, bowel elimination, whether they have an ostomy. We get into your equipment and supplies. So again, if the patient had a ventilator, we're asking you for the type of ventilator, but you'll also have the ability to go ahead and put it in your ventilator flow sheet with all of the settings immediately built in based upon the type of vent that particular patient is using. This gives you those vent settings, and you can document those on all of your visits as often as necessary. You have all of your other equipment types, supplies used and quantity, supplies needed, which again automatically can go to your plan of care, and also to an ordering screen to help you with ordering new supplies. Any treatments that have been utilized, and then we do a quick risk assessment for all of our patients. Prognosis, how that goes to the plan of care, rehab potential, safety measures, activities and functional limits, risk for hospitalization, abuse or neglect, their emergency preparation status with your built-in DNR codes, your triage and risk levels, your emergency and evacuation plans, and then your homebound assessment. We really streamlined the homebound assessment on this one so that it matches almost directly. This is almost verbatim what the Medicare guidelines, which is what stipulate for homebound, which is what most other payers that require homebound would stipulate as well. But in addition to just the words, so for instance, your documentation for Medicare homebound status has to show that the patient, in order to leave their place of residence, has one of these three conditions or these three issues, or they have this particular condition. However, you can't just blindly write down this the statement straight out of the regulations, right? You have to actually give a reason for that, and so that's what the system does. Once you say the patient needs the aid of supportive devices, right, the system immediately gives you the capability of documenting that information. So it makes it extremely streamlined. But if I were arguing this to an ALJ, I can now go directly to a regulation, show that ALJ what Medicare requires of a homebound patient, and now I can verbatim give them the exact information where we meet the regulatory requirement. I don't have to pick out different indicators within an assessment. I don't have to try and justify it or jump through hoops to justify it. Now it's immediately available, right within my assessment. All right. Now, on all of our visits, whether that's the start of care or our routine visits, whether for therapy or nursing, the system is automatically going to give me my list of tasks that come from my care plan based upon the discipline of the person completing this particular visit. So this has my nursing task available to me. We also have our full medication profile available. So adding in a new medication is simple. We still have the LexiComp drug database built in. You can put in your status codes. We now also track the risk factors for that particular medication, along with the reason. If you wanted to leave some notes for the patient, you can do that. This is beneficial. We actually just created a press release for the new COPs that are going into effect January 1st. One of those new requirements is your ability to give your patient information related to their care, which would include your medication profile. Well, now you can actually print out a med listing for your patient along with particular notes that the patient may need to know about. And these will be highlighted on that med profile that you give out to your patient, while you can also keep internal notes that only your staff is able to see. For PDN agencies that operate on shifts, and you want the nurse completing your medication administration, you can actually put in the times of day that the patient would be receiving that medication, and the system will prompt on the MAR for the nurse to administer those medications on that particular day. And as we're doing that, the system's automatically tracking our drug interactions for any type of adverse events. We would be able to do a medication review that attaches to our med profile. And we also can print out any of those drug interactions to give those to our patient or send them over to the physician. Because this is an assessment, I would start by creating my plan of care. So you have the ability to have your nurse or your therapist actually generate the full care path for that patient. You can control your episode dates if you want to do that, or the system can default those for you. And now one of the newer, cooler features, I think, is that in addition to most of the time we're creating our frequencies, and now people just type in 3 times a week for 4 weeks. Well, what the system does is, based upon the type of service that you want to render, you can actually start listing that out. So we could, as we start selecting the days when we would like to do a visit, the system is automatically tracking that frequency for us. And it's smart enough to know that, okay, during week 1, we're not doing any visits. During week 4, that's when we start with 2 visits. And so it automatically knows the frequency that we're trying to complete and will build that for us. And that allows us to automatically verify your schedule against the ordered frequency, as well as we currently do, your authorization frequency. So at the time of scheduling, you know that you're living up to your utilization of ordered frequency as well as authorizations. Whether you want us to create a brand new plan of care whenever this visit is completed, and this is kind of the ancillary information that goes on your plan of care. If we need to place services on hold until the authorization is attained, if we need to notify a doctor about any of our vital signs that are out of parameter, if we wanted to send a note to our scheduler, maybe the patient has a lab due on a certain day, or the next time they're going to see their doctor, all of our DME, safety, nutrition, those are automatically created based upon that assessment that we showed earlier. And you can also create your aid care plan at the time of creating your plan of care. And then we would get into the actual care planning stage. And if we had completed that assessment before, a lot of these options are pre-selected for us based upon the medical necessity that the system finds for that patient. But it's now the system, rather than being diagnosis-driven, is very much problem-driven. So if my patient had cardiac dysrhythmia and heart failure, then I can go ahead and create my care plan. If I would have completed the assessment, the system would automatically fill in my problem and give me medical necessity support. For instance, it may say under medical necessity that patient has a history of, patient has current edema of 4+. Patient was diagnosed with CHF within the past month. The problem may be that patient is at risk for hospitalization due to cardiac dysrhythmia. And then we get into our assessment, instruction, procedures, communication, and goals. So you always have our built-in care path as well, which makes it very easy for you to develop. Just select off on the interventions that you would like to include on the current plan of care. And these will flow through to your care path, which is constantly updated. You also always have the ability to put in custom items. Okay. And those are broken down into the different body systems or emergent care problems that most of the payers are concerned with. So integumentary, whether the patient has a new or changed medical condition, a new or changed medication regimen, which again, we would know if the patient had been had their medication profile updated within the past 3 weeks. You'll automatically have medical necessity for some of these things. Mobility, neurological, pain, respiratory, and social financial issues. You automatically have those protocols built in to the system. So if we were going to teach on ventilators, we have all the ventilator education built into the system. If we were going to perform a ventilator procedure, you're able to put in the frequency for how often you're going to clean the vent or update the vent settings, etc. And so you're actually able to build your care plan just right here with the click of a button as part of your assessment. And before we end our visit, we would go to our communication section, and part of for instance, with our new COPs, one of the requirements there is that there needs to be a lot more care coordination amongst all of your interdisciplinary team members. And so what we've done is now, before you finish your visit, you're going to have to tell us, are there any new problems that that the patient or the next clinician needs to monitor? If you say yes and put something in here, for instance, patient complains of a fever at 11 a.m. Nothing else. We can create communication notes or incident reports. Submit that. Then when we get to the end of our visit, we can get our patient's signature, we can get our signature, who we turn care over to, the date, et cetera. And then when we go to close out, of course, the system's going to automatically validate against all of those errors that we may have, which in this case, of course, we're going to have a bunch. So if we would have finished up that visit, it's either going to immediately update our schedule and go to billing, or it's going to go into our care validation platform.